Yeah.
And they're saying, oh, I just have a injured disc, and I'm like, well,
It's
a
just,
lot of us do.
it's extremely common, and at this point, it's probably just a natural, effective aging.
Yeah.
You know, it's a little early in the 20s, but I try to educate my patients to make sure that they understand that doesn't mean they're going to be in pain. If they do the right things, they should be able to get out of pain. That shouldn't mean anything. Regardless, what are we missing? That transverse process technique. So just coming out here, very, very, very lateral, all the way out here. That's how I have to get to it. Because I want to get on the lateral aspect of it, not the posterior aspect. I'd be going through too much soft tissue, wouldn't be able to get to it. Lateral side of it, that's how you can contact that QL where it attaches to the TP. And you're also working the deep rotators at their attachment to the TP as well. So all those muscles can become problematic. That's a technique I don't use very often, but the few times I have, I find it useful. Okay, enough of that. Remember how this guy was with forward bending? Mm-hmm. All right, so I think he probably needs a little bit of this, so I picked him. Go ahead and go to your hands and knees, please. So we did the laminar release in prone. And like I mentioned, that's an excellent technique. It's extremely effective, but sometimes patients are going to need a little bit more. So if you want to improve forward bending and you think that the limitation is due to myofascial restrictions, then these are excellent techniques where the patient is actively participating. I'm going to show you a couple different variations, and you can use them in the thoracolumbar tissues, and then you can also do similar techniques in the neck. We're just going to kind of show you all these laminar release techniques that you can do. These are really useful, really good stuff. You don't even need a table. I mean, you could even have a patient on the floor doing these, and you could be working with them at the same time.
Would a variable be more beneficial for impulling so you can relax more?
What do you mean? Where?
Having them lay over a variable?
No, because I don't think they would relax more. I think they'd tighten up more because you're on an unstable surface now. He's on a stable surface. He's not going to feel like he's going to fall over. Now, there are some situations where I think patients can benefit from stretching over the Theraball, but doing myofascial work on an unstable surface, I just don't think that's going to work. But you could try it. Good luck. All right, so page 234. So before, we went down that groove with our thumbs together, right? And the patient was in a prone position, so that was a bit more specific. Now we're going to use our fist, and I'm going to start with a very relaxed fist, and I'm going to be rolling down, once again, targeting the tissue in between the SP and the TP, but a broader contact than I had before. I'm going to have the patient, while I do this, I'm going to have him going into a child's pose, essentially, right? So I'm going to show him beforehand what I need him to do. If you're working with a female patient, you're going to have a gown on, gown tied up here, and then gown tucked in right here. So this area is open, that way you can open the bra and you can be confident that they will be covered. When you tuck the gown in, tuck it in down here, not up here. See how if we tuck it in here and then they move back and it falls out, they're going to be mad. Go ahead and come back up. So I'll go over that when you guys are setting up for this technique. Regardless, he doesn't need a gown. So the movement's going to be, you're going to start here and then you're going to sit back on your heels with your head down, and I want you to go as far as you can comfortably. How's that feel to you? All right, he's okay with it, so we're going to go with this. I'm going to start once again mid-thoracic. I'm going to start cephalic to caudal, and I'm going to be manipulating the tissue as he moves into that position. So go ahead and bring your hips back to your heels, and I'm trying to pace myself with him, and then come on back up, and then do it again. Drop back, drop back, drop back. I'm in a great position ergonomically where I can get a lot of depth, but I'm not trying to just push down, I'm trying to push longitudinally. So I can go cephalic to caudal, I can go caudal to cephalic. What do you think's more aggressive? Top to bottom or bottom to top?
Top to bottom.
Top to bottom, because when I get down to the lumbar spine, they're elongated, right? So I'm manipulating lengthened tissue. So this is more aggressive for him. Now we can go this way, go ahead and bring it back. Now this is slightly harder for me because I'm working against him, but it's not more aggressive. Come on back up, and again, drop back, drop back. I like this because he's participating, he's moving, and I've just taught him his home program, right? We're done. So I could just be like, okay, I gotta write a note, keep your head down, stay right there for a minute, and then I could go write my note. And then I could tell him this is what I want you to do at home. I gotta get a picture of it for him. If he had restrictions on just one side, I'd probably give him this stretch with a little bias, right? So now he's got that, and he can do that at home. Go ahead and bring your arms back, and and then come back. And of course, we can do the other side. If I need to do the other side, what do I need to do? I need to go to the other side of the table, right? So only manipulate the side that you're on, otherwise you're just setting yourself for an ergonomic disadvantage. So that's the first picture. So we go top to bottom, bottom to top. This one shows how you can also, in the same position, manipulate the structures around or the myofascial tissue around the thoracic spine. And this one's never been in the manual, so we've never taught it, but I'm going to go over it because I do think it's a good one, where you can go ahead and drop into that same position. And actually scoot up here closer to me. Thanks, yeah, good, very good. So we can get him into a lengthened position, and I can manipulate this way as well. Yeah, everybody loves this. So you've got a patient with some tightness in the traps and the levator scap, lacking, those patients that are lacking thoracic spine extension. So you can get them into this position, and you can manipulate that soft tissue. This is good stuff. Now let's turn the page. Go ahead and sit up. Turn and face your classmates over there. That way. So I like to do these in a chair, but I'm going to do them on this table because I think this will work okay too. So if, let's say, maybe quadruped isn't working for you, or maybe you've got a patient that specifically wants to work on forward bending. Like, for example, maybe you have a patient that has limited forward bending and can't put his shoes on. So this may be more closely replicate the specific activity that he wants to be able to do. Who would you not do this on? Once again, our disc. Yeah, our disc patients. It's not a good position for disc patients, but they may be able to get, if they're in an appropriate phase of their rehab, they may be able to work on flexion in that quadruped position more safely. But for some patients, this can work really nicely. So what I'm going to have you do is I want you to bring your head down, bring your hands between your legs, and reach toward the floor as far as you can go. And now come on back up, and I'm going to be manipulating at the same time. My thumbs are pointed down, my arms are straight. If I bend my elbows, I'm going to have to work harder. So as he lowers down, I try to pace myself with him. Come on back up. So here, it's not an excessive amount of internal rotation. It's just the fist is kind of in line, or the thumbs are in line with where I'm going, or kind of directing my way. He shouldn't feel a lot of pressure from my thumbs. The thumbs are kind of just leading the way. The fist is what's doing the technique. Now let's say I wanted to bias his left side, since we spent all that time on the right. Now I want you to go forward and slightly to the right. Bring your arms around your right leg. Now come on back up. Excuse me. Go ahead and go. Go, 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 go. So I can work just the left. Now come on back up. Let's work the left again. Go, 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 go. I'm supporting him with my right arm. Come on back up. I can do the right. Of course, go to the left. So we can work this way. Come on back up. Okay?
That's great.
I forgot to mention, when you're doing the quadruped, if you get them at end range, go back up onto your hands and knees. Let's go over this because I think it's worth mentioning. When you go ahead and, let's say we did this, go ahead and go down, 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 down. And let's say he was tight just in the lumbar region, you can keep him there. Do a few extras. So you're in a really good position to really make a change right here. Now come on back up. Let's get him out of there and let's do it again. Go all the way down, all the way down, all the way down, all the way down. And now keep him there.
What's your contact point? Are you using your thumbs right
No, fist. Fist. Nice flat fist. Like this. Now go ahead and sit back up again. So from a seated position, we can also work. Come over here to this side of the table. Go ahead.
What's the likelihood a patient might have kind of hypertension when they change in positions going down?
So hypo or hypertension. So that's something that you should already know from your medical history, right? So when you do your history with the patient, you're asking about, you know, I always ask my patients if they have any history of hypertension. That's one of the standard questions that we ask. Additionally, you're asking them what medications they're on. So if they're on blood pressure medications, you already know that. If you've got a patient that has difficulty changing positions, you would already know before you get here, because in your evaluation, you have them change positions all the time, right? So if they're experiencing stuff like that, I might decide to just avoid things like this. And honestly, though, patients that have that unstable hypertension probably aren't doing this for other reasons. Like physically, they probably can't do it anyways. So personally, for patients that I've wanted to do this on, that's never stopped me. Because I think my patients that have that issue are just physically incapable of probably even getting in that position.
You could just not change as quickly, like you can.
Or you could go
stay
slower,
in
yeah.
position.
You could go slower.
Sure.
You could modify it.
Okay.
I just don't find that to be as much of an issue just because, like I said, I get a lot of patients that have hypertension and things like that, but they maybe just couldn't do this anyways.
Okay.
But, good point, good point. Okay, so now what we're doing is looking at the techniques on page 238. So we can do, we can, in the same way, work the tissues around the neck. And I'm a big fan of this stuff, personally. It's done to me. All right, so same deal, right? If I want to work lever, scap, upper trap, I have a couple choices. I could have him side bend away like that, or I could have him look toward his opposite armpit, depending on what I'm trying to bias, right? So I want you to go ahead and look that way, and then come on back up. So I'm going to be here, and then I want you to look that way.
Is this thumb contact or is this?
No, never
Wrist?
thumb contact, never thumb contact. You'll notice in this course, we aren't big on the thumb. Now come on back up. Anybody have exposure to active release techniques?
Yeah.
Yeah, so I've done the certification, active release, I've done all the courses, and I think there's a lot of value, and this is very similar. The ART technique would be to tack it down, go ahead and look down to your right, and I use it all the time, I think it's really good. So it's a bit more specific, it's a bit more aggressive, and then come on back up. But the techniques besides that one and a couple other ones are so hard on the thumbs, and a lot of people just don't do them for very long. They're hard on you. This is just an alternative. It's a similar technique, you're gonna get similar effects, but I do use some ART techniques, that's one I use a lot. Look down and to your right again, regardless. This is a good one. And then come on back up. Now I want you just to side bend to the right, side bend to the right. Yep, there you go, good, and I can work right over that upper trap. Now I could keep him here, same deal, stay here, and we could just work over there. Go all the way. Go all the way. If you feel something bony, don't dig your knuckles in. That doesn't feel good. Good, so you can work it that way. What else? We've got one other laminar release, and I don't know what page it's on, but it's in here somewhere. Roll to your side and face me. So I mentioned before, if in doing that prone laminar release, you think that you find a specific area, like let's say I think just right here is tight, and I want to just focus on that. Now you could do that in quadruped, and that'd be what I'd be most inclined to do because it's physically easier than this. But if you've got a patient that maybe you're going to do a lumbar manipulation, then this can be great because you've already got them in the position, so they're ready to go. This particular technique, you need a patient it's called side-lying laminar release. You can find it. 231? Oh wait. Yeah. Yep, there it is. There it is. Forward bending laminar release and sideline. So this is just another laminar release where we're forward bending. So for this one, you're right up next to the patient, pillow in between you and your sideline patient. And let's say I wanted to focus just on this area. I felt like this was the tight area and this.
Bless you.
Then what I can do, I can get his leg anchored in here, right there. And then I've got a hand here parallel to the table, this hand's stabilizing, this hand's manipulating, and I can forward bend him and manipulate. Forward bend him and manipulate. Forward bend and manipulate. I do like that one for little patients. I've got little people. Then I feel like sometimes I can get control of it, and then you may want to go right into a lumbar roll from there. So that's the convenience of that versus quadruped, less position changing, things like that, but it's physically way harder than quadruped. But it's another option, you want to be familiar with it. More passive on the patient's part because you're doing all the work for them. But it's great to focus on a little area. Small, then you could move down here and you could do that too. So let's go ahead and practice all those for the next 20 minutes. So 10 minutes each, try to get through all those laminar releases. You can start with sideline, go into quadruped, do the seated, get the neck, get the low back, get the T-spine, get them all released, and then have them stand up and recheck their forward bending. So check forward bending first.
A little high there? Did you have to get like a running jump?
They're standing on their own now.